Welcome to the Boston Structural Heart Disease course. My name is Feroz Mahmood. I am the Director of Cardiac Anesthesia at Beth Israel Deaconess Medical Center and Professor at Harvard Medical School. Today, I will be giving you a brief but a comprehensive outlook of the scope of structural heart disease interventions. We'll go over its definition, the entire scope of what structural heart disease is, the history, the present, and of course, then we'll venture into the future of what it is likely to look like in the coming decades. My purpose is to give you a brief outlook of what the current status is, and at the same time with particular reference to the imaging challenges and the applications of three-dimensional imaging to facilitate the structural heart disease interventions intraoperatively. We'll specifically address the role of transesophageal echo and three-dimensional imaging in this presentation. So now structural heart disease interventions are performed in the hybrid operating rooms most of the time in a heart teams model, which implies that every member of the team has a specific role to play. And us as imagers are also an integral component of this process. And it's a very high impact role, and that's because of our expertise in three-dimensional imaging to provide real-time synchronous procedural guidance. So that's what brings us to the table, and that is the ability to provide procedural guidance using real-time three-dimensional imaging. I'm often asked this question, what structural heart disease interventions are and what structural heart disease is as such. So there's no particular specific dictionary term to it, but it was a term first used by Marty Leon from Columbia University in 1999, where they defined it as an overreaching term encompassing non-coronary cardiac disease processes and the ability to develop interventional techniques to treat them and to correct them. So it's non-coronary intervention. So stents and all that stuff doesn't really come into structural heart disease interventions. Now, the scope of structural heart disease interventions is limitless, and it is purely limited by technological impediments and not our intellectual reasons, because we can do a lot of things that were considered impossible 10 years ago that could be performed are now being done routinely on a daily basis, and that's because of technological innovations, the catheters becoming smaller, thinner, requiring less of invasive techniques to introduce them into the intracardiac space, and at the same time, the ability to see them in three-dimensional imaging has made those things possible that were things of in the realm of impossibilities over time. So therefore, the scope of intervention will continue to increase as long as the technology keeps progressing and keeps getting better. Now, the disease processes that can be dealt with and that can be treated with interventions is changing its scope. It was used to be purely for valvular heart disease, such as mitral valve prolapse or valvuloplasties for mitral stenosis, but now hypertrophic obstructive cardiomyopathy, paravalvular leaks, congenital problems, left atrial appendage occlusions, and also other congenital abnormalities are being routinely treated with the structural heart disease interventions. And it's not like any other technology, a solution that is looking for a problem. It is a problem that required a significant input as the patient gets older and they're surviving more and more. They are coming to those in that stage of their life where open surgery is far too invasive and far too complicated for them to sustain, and therefore, or expensive for that matter. And therefore, we need to devise some therapeutic interventions with which are minimally invasive and do not cause as much anatomical or physiological disruption, and therefore comes the structural heart disease interventions. And now it's a pretty wide open field. It is not really specifically defined at this stage that who owns it, or is it really a new specialty that has come to life because it's cardiac surgery. Cardiac surgeons are doing structural heart disease interventions. Of course, the lion's share is being performed by cardiologists, the radiologists, and using the interventional skills sometimes do these things. And anesthesiologists, particularly the cardiac anesthesiologists with their expertise in echocardiography and three-dimensional imaging, tend to share the space with cardiologists as a procedural guide for procedural guidance. And now, whether this transition from who does what and to what extent and what is a specific specialty's role is a matter of definition. And so far, it's not a very orderly transition, and it's kind of a Wild West and everybody doing whatever they want to do, and seems like a pretty anarchic transition and anarchic field with a lot of people jockeying and trying to claim position They're doing all this sort of stuff. So and it's good in some sense and bad in others, because there's no specific guideline to how to do it, and most of it is uncharted territory as we're going along with this thing. So it's a race for recognition, and a lot of people think that and assume that it's related to money, because it depends on who gets paid more. Is the interventional echocardiographers, even interventional surgeons. There's a term like this sometimes used, and it's purely driven by reimbursements, and meaning that as the people get older, we can perform procedures better, safer, and cheaper, and the overall cost to the system and society is less, and people get back to work sooner with less time in the hospital. So it's a win-win situation for everyone, both fiscally, logistically, for patients, system, and the doctors as well. So let's go over the history of interventional procedures, how they came into play. So the first cardiac intervention, if you call it, was performed by Stephen Hale, a priest in Europe, in a horse in 1727, when he used pipes to reach the animal's ventricles and recorded pressures, the venous and arterial and the intracardiac chambers. The term cardiac catheterization was coined by French physiologist Claude Bernard in 1885, and then it didn't really take off until after the X-rays were discovered by Willem Röntgen in 1890s. And then you fast forward to 1977, when the first angioplasty was performed, and that again was a huge jump from what it was done in the beginning to what it came with the help of X-rays and real-time angiography. The earliest evidence of use of imaging as a procedural adjunct was during First World War, when radiologists used the help of real-time fluoroscopy for extraction of bullets lodged into soldiers to avoid major mechanical or anatomical disruption. So interventions using imaging as a procedural adjunct were not new, but they were restricted to procedures like this, which are performed in emergency to either save a limb or life. But when it came to the cardiac chambers, the real problem was crossing from the right to the left side, or from the left to the right side, and the major barrier that people encountered or thought of as the major impediment to doing any structural interventions percutaneously with fluoroscopic of X-ray guidance was the intra-atrial septum, and that was the major problem in crossing or performing any interventions. Whereas on the right side you could stay and hang out and do things, but crossing to the left side was a very big deal at that time. So to go over the history of transseptal puncture takes us to Bellevue Hospital in New York in 1947. And Bellevue Hospital, incidentally, is the same place where Dr. Halstead began his medical career and learned the earliest techniques of surgery and started those innovations in education, particularly graduate medical education, that are practiced to this day. And the famous Showtime series, The Nick, sort of is loosely based in the Bellevue Hospital, and Clive Owen also loosely based his character of Dr. Thackeray on Dr. Halstead. Well, that was historical trivia, but that's exactly the place where the first transseptal puncture was performed by Dr. Cornyn et al. In 1947, when, while performing a right heart catheter in 3 patients who had atrial septal defects, they inadvertently crossed onto the left side and were able to measure the pressures on the left side of the heart. So the value of the pressures on the left side of the heart was immediately recognized, and people started accessing the left atrium from multiple anatomical routes. There was the bronchoscopic route, where people went through the right mainstem bronchus, the suprasternal notch, or the paraspinal method, in which, using fluoroscopy, a needle was inserted through the mediastinum into the left atrium. Now, you can imagine that these are very invasive methods and must have had some morbidity associated with that, and they were based on normal anatomical orientation of the heart, normal cardiac anatomy, as well as mediastinal anatomy. Therefore, unfortunately, they didn't take hold as the prevalent methods of accessing the left side, but people were trying to do that until in National Institutes of Health in 1958, when Dr. Ross, Brownwell, and Morrow, 2 cardiac surgeons, Morrow and Ross, and Dr. Brownwell, a cardiologist, devised a method of crossing the right side to the left side from the right side, using a special transseptal puncture needle to the fossa ovalis, avoiding injury to the heart or accessing the extracardiac space. And that kind of revolutionized our access on the left side, and that is a fluoroscopic left-sided puncture. However, as soon as they discovered this thing, another technique came into practice, and that was the Swan-Ganz catheter, which was inserted through the right side, stayed on the right side through the right atrium ventricle to the pulmonary artery and then you could indirectly estimate pressures on the left side, and therefore there wasn't not much need to go to the left side of the heart because everything that we did on the right we could indirectly estimate with a degree of accuracy pressures on the left side. So transseptal puncture was limited to either crossing over to the left side to measure left atrial pressures or arrhythmogenic surgeries that people used to do. Now, at the same time, while this thing was happening, there was simultaneous development of transesophageal echocardiography. Initially, in University of California, San Francisco, where Dr. Frazin in 1976 attempted to use an esophageal stethoscope, that's what they called it, in patients who had horrible or very difficult transthoracic windows. The problem was that the probe, as you've seen on this side, this one, was pretty big and there was significant gagging associated with it. So they did that in a bunch of about 30 patients or so and then gave up that idea. But at the same time, Dr. Matsumoto in Albert Einstein College of Medicine in 1980, this is about 4 years later, was trying to develop an epicardial stethoscope to go into the surgical field while the chest was open to do M-mode assessment of the left ventricular and right ventricular function, both systolic and diastolic. But the problem was that they had to interrupt the surgery. There was a disruption of the sterile field or the possibility of doing that. And of course, the surgeons weren't very happy. And he was about to give up his procedure when, through a series of conversations and encounters, they were able to use the esophageal stethoscope, that is the delivery device that Dr. Frazin used, and they mounted their own device on top of this catheter, and they formed the first transesophageal stethoscope. And the major reason for that was that they didn't want to really interrupt the surgery, and that's how TE became a very usual monitoring modality during cardiac surgery without interrupting the surgery. So that was happening at the same time, while Swan-Ganz catheter was introduced, which kind of took over most of what the left-sided access was supposed to provide. Now, transesophageal echocardiography is a very interesting history of its development. It was like in 1950s and 60s when it was demonstrated to have some clinical potential. The majority of its use was restricted for assessment of left ventricular function purely as a monitoring modality, more so during non-cardiac surgery, because cardiac surgery didn't happen as much. But as you can see, we wrote that in this article also, that there was a series of technological developments, people using it in innovative fashions, that it became from a monoplane to a biplane to an omniplane to a three-dimensional and finally a real-time live three-dimensional imaging monitoring modality, which has gradually evolved from just a monitoring modality to a very vital and integral procedural adjunct, not only during cardiac surgery, but also during structural heart disease intervention. So that's, and at the same time, while the echocardiographers don't get that much credit to this thing, but you see that the structural heart disease interventions, until the availability of real-time three-dimensional echocardiography, if you plot its application over time, you see was limited to very simple, straightforward access to the left side, measuring the pressures, putting in VAD devices or something like this. But as soon as the real-time imaging became readily available, the complexity and the volume has taken a very incremental turn, and now we perform very complicated maneuvers requiring very strict, precise motion of devices in the intracardiac space. And the most important thing in this one is crossing the septum from the right to the left side. And what everybody knows, that fossa vallis is the place where this can be crossed easily without accessing the extracardiac space, and that's the thick part of the intraatrial septum, and also without damaging anything else. So while it may be 1 centimeter by 1 centimeter, but becomes a huge landscape when you really require precision of motion on the left side and precision of intervention on the left side. So it is a huge knowledge and a huge training that is required to optimally guide the transseptal puncture for a device and a therapy-specific location. And one of the major reasons for this becoming very important, that is the three-dimensional echocardiography, is the major difference in the display of fluoroscopy as well as two-dimensional echocardiography. Now, fluoroscopy is essentially a projection of anatomy of three-dimensional anatomy on a flat space, and they position the catheters in space and they move the gantry and the C-arm and they try to see the relationship of devices and catheters in relation to a fixed point in the heart, and that's how they know it's anterior, posterior, lateral, or medial. However, two-dimensional echocardiography purely is a tomographic anatomy, which means you see very thin cross-sections at a very high frame rate and very high line density, which means a good spatial and temporal resolution, but you are devoid of that spatial perspective of what is around that thing. And we will demonstrate that in a fashion that as you look at it in the fluoroscopy, it is an anatomical projection, and the placement of a pigtail catheter in the aorta being the reference point, and everything else is seen in relation to the position to that pigtail catheter and the projection or the position of the camera as well as the gentry. So it requires some reorientation, but it is not a tomographic projection, and you have a flat display of three-dimensional anatomy in the heart. Quite to the contrary, if you look at echocardiography, that is tomographic sections at very specific locations. So therefore, it becomes a little issue in reconciliation of anatomy and terminology between fluoroscopy and echocardiography, and it also requires, besides precise knowledge of the fossa vallis anatomical relationship, is also the reconciliation of terminology that we have with the echocardiographers. For example, as you can see in this specific slide, you can see that the transthoracic echo, again, a tomographic section of a very, very complex display of an anatomical structure is being shown only as a single scan plane. It becomes a little bit more complicated if you look at transesophageal echo, which means not only you are looking at a very tomographic section only, but also from a very different and a unique perspective, that is from behind the heart in the esophagus looking up, and the image display is significantly different, and therefore the directionality and the laterality is significantly different from what you look at. So having said this thing, what does three-dimensional echocardiography bring to the table that is so unique? So as you can see on the left is a two-dimensional image. On the right side is the same image but with the perception of depth. So what three-dimensional echocardiography has brought to the table is the z-axis, which means you not only are able to see the length and breadth, but you also appreciate z-axis or the elevational aspect of it. Whereas in reality, on a flat projection, there is no z-axis. It's only a perception of it. But that's what is the perception of depth that is created, and therefore you can move in directions that are otherwise not possible to do it. And that is three-dimensional echocardiography produces a perception of depth on a projection. That's what the value of it is. And as you can see, that the fossa vallis, the right side of the heart, are really complex anatomical structures with close proximity to very vital structures: the aortic sinus, the coronary sinus, the bundle of fish, the tricuspid valve. So the potential for injury with all the motion of the heart and the transnational aspects of ventilation are important considerations for moving intracardiac catheters. And unless you have that perception of depth and z-axis, if you're moving it only in two axis without knowledge of what the depth of the z-axis is, the potential for injury and damage is significant. And what it brings to the table is the anatomical correlations with the spatial perspective and dynamic anatomy with the perception of depth, which means you can read about this anatomy and the relationship of the aortic and the mitral valve, but this is one projection that you can look at and say and appreciate that in very, very quickly. And also it creates sections of the heart, the dynamic display of anatomy, which is otherwise impossible to see even if you're performing cardiac surgery. For example, this view of the aortic valve, this view of the mitral valve from a left ventricular aspect, when you're looking at a fish mouth view, it just implies that you really do not know unless you see it and unless you appreciate the complexity in real time. Now, let's get back to the fossa vallis and atrial septum, because this is what it is all related to. And that is the difference between the false and the true intraatrial septum. The false septum being this portion of the septum between SVC and the fossa vallis and the IVC and between the rim of the tricuspid. This is, in essence, an extension of extracardiac space in and around the fossa vallis. And if the needle was to go anywhere through one of these portions, you would have to traverse the extracardiac space before you get into the left atrium. So the only safe space for crossing the intraatrial septum is the fossa vallis, and that's where the definition comes important, and the value of transesophageal echo becomes very important, because it is vital in positioning this transseptal puncture needle within this fossa vallis and avoiding the extracardiac space. And now, using three-dimensional echocardiography, we take the guesswork out of it, and we can even put extra markers in the 3D space, which means this red corresponds to the superior margin, this yellow corresponds to the inferior, green to the anterior, and the blue to the posterior to demonstrate that the position of the needle, which is being demonstrated with this indentation, with a degree of precision. Now, there's no guesswork involved whether you want to go anterior, posterior, superior, inferior. And once the catheter passes through that location from the left side, and as you see in a view on the inside of the right atrium, so inside of the left atrium, the exact and the precise position of the transseptal puncture has been demonstrated in this one. Now comes the reconciliation of anatomy that I talked to you in the past. As you can see in this animation, the patient is lying down flat, the TE probe is in the esophagus, and the heart is in this location. And as you can see that you are here in the esophagus, and the scan plane that comes out of the transesophageal echo probe goes like this. However, when the image is created, it is not only turned upside down, but turned to left to right side to give you the impression that we are going from left to the right side, which means when we ask somebody to go towards the apex of the heart, when the patient is supine, that implies moving upwards as opposed to going downwards. This is going to become a little bit more complicated and a little bit more confusing as you look at in the next slide, which means the position of the heart is here, but it is being displayed like this, which means going from the septum or going from the annulus of the mitral valve to the apex, according to this image, would imply go from up to down. But in actuality, in real time, in three-dimensional space, what you are doing is going from the annulus upwards. So it's what we say in the image and say go down. In an absolute space in anatomy, it is actually going upwards. So that reconciliation of anatomy and reconciliation of terminology between the interventionalists and the echocardiographers is extremely essential in this structural heart disease space. So this nomenclature creates a significant confusion, and there's a huge area of growth and work if somebody wants to work on this thing. So what appears inferior actually is interior. That's what the bottom line in this situation is, So when we look at a guidance of catheter from left atrium to left ventricular apex, when we're moving the catheter, we tell those people, start in LA, go down through the mitral valve, further down to the mid cavity, and further down to the apex. In reality, what we are asking them is to go in the left atrium, move anteriorly to the apex, to the mid cavity, and finally to the apex of the ventricle. So let's go over where we stand presently as it relates to structural heart disease interventions. So transcutaneous aortic valve replacement was the first major structural heart disease interventions, one of the major structural heart disease interventions with a very global impact, particularly on cardiac surgery, with the aortic valve replacement being one of the most frequently performed operations in the early 2000s to being the least frequently performed operation now as a result of this thing. Now, the timeline of TAVR is that the first human transcutaneous aortic valve replacement was performed with Dr. Elaine Tribier in 2002. And since then, it has been going through a lot of different trials, the more important one being the Revive, Recast, Seberg study, and finally the Partners trials 1A and 1B, which was with a core sapien valve after it received a CE mark, that's the FDA approval for Europe in 2007. And we were at the Beth Israel Hospital, part of this Partners 1A and 1B trial. And it went on to Sapien XT, then we went on to more clinical trials after the results of Partner 1A and Partner 1B were published. Initially, when in 2010 to 2012, the core valve, which is a Medtronic's valve, was FDA approved for extreme risk patients. And then it gradually advanced to high-risk patients. At the same time, the Sapien was for initially November 2011 for inoperable aortic stenosis, then for high-risk AS. And then came the Partner 2B trial, which for core valve was approved for extreme risk AS and approved for high-risk severe aortic stenosis when they demonstrated non-inferiority as it relates to surgical aortic valve replacement. Then came the CERTAVI trial when later on, in 2016 or so, it was approved for the intermediate risk of aortic stenosis. And then came some more kinds commercially available, the Evolute valve, which were the further enhancements of the initial ones. And as a result of the CERTAVI trial that concluded in 2017, we have now come to start doing TAVRs for patients who are considered low risk. So from 2002 to 2017, is about 15 years, has pretty much changed the landscape of cardiac surgery, particularly as relates to aortic stenosis and aortic valve replacement. That it started off as an experimental therapy, and within 15 years, it has been approved in the United States for as being non-inferior to surgical aortic valve replacement for aortic stenosis. In the market, we have clinical choices. We have Edwards Sapien, the Sapien XT, and the Medtronic's core valve. And both of these valves are deployed percutaneously through the femoral artery. The Edwards Sapien is a stainless steel frame with bovine pericardial leaflets and compressed into a low profile, and is a balloon expandable valve and can be introduced through the femoral artery or the cardiac apex, either way, for those who do not have good vascular access. The Medtronic's core valve, on the other hand, is compressed into acute tract delivery catheter and introduced through the femoral artery or the subclavian artery. This cannot be introduced through the femoral to the cardiac apex. The Sapien valve is a balloon expandable, which means the balloon and the stent has to be positioned very precisely. Initially was used with transesophageal echo, now with fluoroscopy between the leaflets of the aortic valve, and a balloon expands the valve, and then you may have to do further expansions to properly seat the valve. The core valve, on the other hand, is a self-expandable valve, which in the latest iteration can also be recaptured multiple times to position it optimally between the aortic valve's leaflets and to avoid coronary occlusion and damage to the other structures. Now, the mitral valve is a little bit more interesting because it's a valve which opens and closes actively and not as a result of simply pressure changes. And this is where the echocardiography has made the most difference, because we have introduced these en face left atrial and left ventricular views of the mitral valve, which correspond to the way the surgeons look at the valve when they open the left atrium. So this is also sometimes referred to as the surgical view of the aortic valve. And as a result, we kind of have a common terminology, common orientation of the way we look at it. And that has made a significant difference in which we address the percutaneous interventions to the mitral valve. And the most important intervention, that besides the balloon valvuloplasty for mitral stenosis, is for mitral regurgitation. Now, the amazing thing here is that mitral regurgitation is a pretty prevalent disorder, and of the patients that are eligible for surgical therapy, only 2% are actually referred for surgical therapy, and the rest of about 98% of these patients are too high risk to undergo surgery and are denied this operation because of either being ejection fraction being severely depressed, and then otherwise and more than about they have advanced stage, so that they are considered too high risk for going in for a surgical mitral valve replacement. Now, mitral regurgitation, as you can see, is also not a very benign procedure, because increasing mitral regurgitation leads to increased stress, muscle loss, damage, LV dysfunction, dilation, and eventually more tension. And if it's untreated, severe mitral regurgitation leads to about 60% mortality within 5 years of being diagnosed. Now comes the more important therapy for mitral valve, and that's the MitraClip, often referred to as the edge to edge therapy. And it received the CE mark. That's the European equivalent of FDA approval in 2008. And it was first a commercially available device which enabled a non-surgical option for patients suffering from effects of mitral regurgitation. Now, the inventors and the people who initially designed the eValve company was bought off by Abbott for $410 million. Well, that was the right time to be in the market for that. And since then, it has also been kind of fast-tracked into getting an FDA approval for functional mitral regurgitation. There was the 2012 COAPT trial was initiated, which was a randomized open label. They enrolled about 610 patients for efficacy of edge-to-edge repair in symptomatic heart failure patients to measure 2-year impact on mortality, hospitalization, and that did demonstrate a lot of positive results. And now edge-to-edge therapy has become kind of a 2B recommendation for patients in heart failure secondary to mitral regurgitation. Whereas the initial trial in France did not show that much of its efficacy, but the significant design flaws and methodology flaws that led to this equivocal results in that trial. But the COAPT trial has kind of put it beyond any reasonable doubt that this really helps in patients with functional mitral regurgitation and heart failure. So if you look at it, at the way the mitral clip took its shape from its initial introduction as a trial to something being clinically and commercially available. It's about 14 or 15 years when Everest 1 was a feasibility trial in 55 patients, and then to 2003, 4, 6, and 7 came the Access Europe trial that was a commercial trial, and at the same time happened a Realism trial that happened shortly after it received this E-mark approval in Europe. It became available in the United States in 2013, and then we've been enrolling patients in the COAPT and the ReShape heart failure trial since then, and the results were recently published that we alluded to in the last slide. That is, they showed favorable outcomes, particularly in patients with heart failure and functional mitral regurgitation. Whereas this has been a process of evolution. As you can see, that the device efficiency of placements, the timing has been improving. And in all fairness, in our hospital, we have done some mitral clips in as short a time as about 45 minutes. The implant rate has improved. However, the most important thing is the etiology, the mix of the patients that need that mitral clip therapy has gone from 74% having degenerative MR to only 33% having degenerative MR and 67 having functional mitral regurgitation. That's a huge shift in the kind of population that gets edge-to-edge therapy or mitral clip therapy. And as you can see, with the passage of time, as the therapy, as the incision and the access to the heart and mitral valve has become smaller and shorter and more minimally invasive, the involvement of the echocardiographers and anesthesiologists has become maximal, because now with transesophageal echo and three-dimensional imaging, we tend to provide their eyes and their access to the heart that they otherwise cannot see. And as a result now, we can even now percutaneously replace the mitral valves. The patient coming in from home, getting the mitral valve, going home the same day or the next day, which was kind of unthinkable in some patients who are getting second or third time surgery. And as you can see, the percutaneous mitral valve replacement, while not FDA approved right now, there are numerous trials of a few of them which we are part of at our medical center also, involves having suitable candidates which can undergo mitral valve replacement as a primary therapy for degenerative or any other kind of mitral regurgitation. Now, this is kind of the scope and of the structural heart disease interventions that have been doing at our place. Starts from mitral clip therapy. You can have left atrial appendage occlusion devices. You can have valve and valve therapy. Perforations being closed by implanters and plugs, stents in the pulmonary veins, and paravalvular leak closures, which were very morbid operations requiring all those precautions for a redo cardiac surgery now be performed as a day procedure within an hour. And as you can see, these things are not benign procedures. This is a valve and valve, a sapien valve performed in a mitral position. Of course, there's a huge paravalvular leak that leads to almost about a $60,000 valve, floating in the atrium of the left ventricle, atrium and the left ventricle, and the patient at a grave risk of undergoing dislodgement, stroke, or something else had to go on a emergency cardiopulmonary bypass to retrieve it. So the echocardiographic assessment prior to placement and its guidance while it is being placed are integral procedures. And one of the major reasons we can do this thing is that we can produce and give them anatomical display of mitral valve with an absolute precision. You can see the view on the left side, which is an artistic rendition of the way an ideal mitral valve should look. And this is the image that we're able to produce within the heart with an echocardiographic image within a few seconds is mind-boggling. And so therefore we can produce very precise, high-quality anatomical renditions of mitral valve in real time to assist in decision making. And that's because we are not only able to see the leaflets, but also analyze the mitral valve as a part of an apparatus that has chordate tendonae, leaflets, mitral annulus, part of the left atrium, left ventricle. And all this can be analyzed in a dynamic fashion, being exposed to the rigors of preload and afterload, rate, rhythm, and contractility, which when performed surgically cannot be done as easily or impossible to, because the heart is paralyzed on cardiopulmonary bypass and hence does not display that dynamic physiological interplay of anatomy and physiology at the same time. And we can measure the degree of the flail gap, the flail width, and how many chordae, how many leaflets, and how many scallops are involved can be performed and be told to the surgeons in real time. So therefore, the involvement of echocardiographers and anesthesiologists in structural heart disease interventions goes far beyond just providing monitoring and keeping the patient alive. It goes from confirming the diagnosis, assessing the suitability, guiding the procedure, finally establishing success, and lastly, to exclude complications. So it's a kind of a operation that goes involved from A to Z, and you're the last person to pass to give a tick mark of approval or of the seal of approval whether this process or the procedure was a success. For example, as you can see in this atrial septal defect, you can see it in real time, a device being dislodged in the left atrium as it is being pulled withdrawn into position at the left atrium, and finally will be lodged over here in the atrium. Now the disc on the right side will be deployed, and as you can see, the device sits in an atrial septal position, completely occluding the atrial septal defect. And in any other situation, you'd have to require open surgery for this procedure. And sometimes we not only are able to guide the procedure or demonstrate when this patient is not suitable for this thing. For example, this patient referred for an atrial septal defect demonstrates that does not have good stable rhythms or stable rims of the interatrial septal defect to be able to support a device placed in this one with a high chance of dislodgement. Similarly, in an aneurysmal intraatrial septum was referred for an atrial septal device occlusion, and just one cursory look at it demonstrated that this flimsy little filamentous kind of structure will be unable to support closure device, and therefore this case was not also performed. So this also demonstrated that we have a significant role in finally confirming the suitability for intervention. Now the logistics of this thing. So the first and the foremost logistics for structural heart disease intervention is the ability to provide real-time three-dimensional imaging. As you can see, this high-quality image of the mitral valve was provided through a very high-quality machine, and this is the level of the quality that is expected and should be provided to our interventionalists if they have to do an intervention. And this is not something, a kind of an image that is for a showpiece image that I used for just a presentation. This was for an actual patient undergoing mitral valve intervention, demonstrating the quality the interventionalists expect from the echocardiographers. Now, all these cases are performed in the hybrid rooms. This is one of the hybrid rooms in our medical center. And you can see that there's a cardiopulmonary bypass, an echocardiography machine here, an anesthesia machine here, and all these monitors and these and the fluoroscopy equipment to be able to display images in various locations, because it's a heart teams model and everybody needs to know what you're doing. And at the same time, the whole operation is performed at the threshold of an intervention, which means that if we have to resort to open surgery, we can do that at the drop of a hat. Sorry about that. So we use that with all regular monitoring, a large bore IV access, an arterial line, the ability to pace, and ability to cardiovert and defibrillate should also exist, because we do not have access to the heart, and therefore anything that we do, anything that is done in the heart can lead to arrhythmias and which can be fatal. So you should have the ability to cardiovert and defibrillate the patient very quickly. Now, going over the edge-to-edge repair, the one that we use more often, or the one that is FDA approved, is the Mitral clip, which has a steerable guide catheter, and the various iterations of the clip on the width of the arms and the length of everything. But at the end of the day, these are the grippers and these are the clip arms, and the leaflets have to be clasped between the grippers and the clip arms before it is closed. And this is what it looks like. The leaflets, it's so precisely positioned that the arms fall between the grippers and the clip arms. And once we ensure that they are in here, the clip is closed to reduce the motion of the prolapsing segments of the mitral valve. And at the end of the day, after the clip has been deployed, the mitral valve turns into a two-hole leaflet. This is analogous to a surgical Alfieri stitch, which is performed between the A2 and P2 scallops of the mitral valve. Now, in this animation, you will see an actual clip being deployed and the method in which it is deployed. It is accessed through the femoral vein. You go through the interatrial septum. The steerable guide and the sheath are introduced into the left atrium. The sheath is withdrawn with the wire after it is ensured that it is in the atrium. And then the clip is introduced. The clip is advanced into the left atrium, all under echocardiographic guidance. Then it is positioned above the mitral valve Then the clip arms are opened in a fashion to be orthogonal to the line of coaptation of the mitral valve. Its ability to move, motion is demonstrated. The clip arms are open and to be seen to be absolutely orthogonal to the mitral valve. And then the clip is advanced into the left ventricle under the mitral valve, and this is how it tends to grasp the leaflets between the clip arms and the graspers. This is how it is done. The graspers are dropped, it is closed, and therefore there is significant reduction in mitral regurgitation after that. Now you've seen this animation, which was an artistic rendition of what actually happens. Now let's take a look at an actual clip being introduced into the left atrium, through the delivery sheath, and positioned above the mitral valve, and you see how much quality we have of doing, how close we come to providing an actual image that looks so much like an artistic rendition. So this is the sheath into the left atrium, and the clip will be introduced shortly. This is the incoming fluid, which demonstrates that clip is being advanced into the sheath to be introduced into the left atrium. The clip comes on into the left atrium. It is advanced over the ligament of Marshall or Coumadin ridge into the left upper pulmonary vein. Once you clear the Coumadin ridge into the left atrium, it is brought above the mitral valve. And finally, the clip arms are opened and positioned orthogonal to the line of coaptation to be deployed at the position of choice or predefined position on the mitral valve. You can see in another rendition, the clip comes on position above the valve. It is positioned at the location that is A2P2 under echocardiographic guidance in real-time three-dimensional imaging. It is advanced under the valve. Its position is confirmed. Clip is positioned below the leaflet. The leaflets are grasped, and finally the valve is converted into a two-hole valve, analogous to a position after a surgical Alfieri stitch. So percutaneous valve therapy is a growth area. It is driven by innovation and patient need. Imaging involved in assessing suitability, guidance, establishing success, and excluding complications. Certainly at this time, there is lack of reconciliation, and it will require reconciliation of terminology and image orientation and display, and this is a huge area of growth. It is a birth of a specialty within a specialty and referred to as structural heart disease, which is kind of based on a TEAMS model. Now, what the future holds, as you all know, predictions are really hard, especially about the future. But what we need to do eventually will be fusion imaging, which means co-registration of DICOM-based anatomical landmarks between different imaging modalities, that is fluoroscopy, echocardiography, CT scan, and MRI, and to fuse them together and co-register all anatomical landmarks to produce a composite image, which is based on multiple modalities, and to be able to do that in real time would be the key part in doing this thing. Where do we stand? Our center stands in structural heart disease. Beth Israel Deaconess Medical Center is one of the leading centers in structural heart disease imaging and management in the country. A few of our cardiologists, Drs. Papma and Ilham, are pioneers in the TAVRs and in the partners trials. We have been pioneers in ASD and VSD closures, leading centers in H2H therapy in the Northeast. We are also a leading center in paravalvular leak and mitral valve therapy, and our unique aspect of our program is the cardiac anesthesiologists are the sole interventional echocardiographers at our medical center. And we are the first ones to have started a structural heart disease imaging fellowship for people who are interested in furthering their career as structural heart disease imagers. So change is inevitable. The major aspect of dealing with change is to drive it and not being its victim. And the best way to predict the future is by creating it. So My motto is let us drive the change and not be its victim, and that's by adopting this imaging modality and this challenge and not be its victim. And lastly, your life does not get better by chance, it gets better by change. Thank you. Thanks for watching the introduction to structural heart disease imaging. This is one of the presentations of our Boston Structural Heart Disease course. Please stay tuned for online launch of the Boston Structural Heart and Boston Echo Boards Review course. We'll be welcoming your participation very soon. Thank you very much.